My therapist said to record these, said externalizing the memory would help more than keeping it in. It's 2 a.m. and I can't sleep again. So, here we go. 28 years in emergency medicine, last 15 at Cook County, Stroger if you want the official name, but nobody who worked there called it that. You learn things at county that they don't teach in residency. You learn that a gunshot wound to the chest is sometimes easier to manage than a psych hold who swallowed a razor blade. You learn that the coffee in the break room microwave is never fresh and you drink it anyway. You learn to trust your charts. That's the thing people don't understand about emergency medicine. We live and die by documentation. Every decision, every dose, every timestamp. If it's not in the chart, it didn't happen. And if it is in the chart, it did. January 2018, Tuesday night. Flu season at county, which means the waiting room looks like a refugee camp and the board looks like an air traffic control screen. But that particular night was oddly quiet. 19 patients at midnight. For Cook County, that's a vacation. I grabbed coffee from the break room. Pot was empty, had been since 10. Microwaved the dregs from my thermos. 2 sugars, powdered creamer. Checked the board on my way back. Usual winter lineup. Flu rule-outs. COPD exacerbation in bed 11. 2 psych holds waiting for placement that wouldn't come until morning. A lac repair and fast track. And bed 4, Raymond Garza, 58-year-old male, chest pain, rule out acute coronary syndrome, first troponin negative, second draw pending at a 3. I stopped by bed 4 around a 1:50. Garza was one of the good ones, pleasant guy, retired electrician from Cicero, sitting up in bed, watching Seinfeld reruns on the ceiling-mounted TV, the one with the bubble boy. He complained about the food. I told him the second troponin comes back at 3, and if it's clean, he goes home. He said that sounded great because his daughter was making tamales on Wednesday, and he didn't want to miss it. That was the last normal conversation I had in that hospital. At 2:33, I sat down at the nurse's station workstation and opened Garza's chart in Epic. I was going to write a quick reassessment. Vitals stable, patient comfortable, plan unchanged, awaiting second troponin. Should have taken 90 seconds. There was already a note there, a progress note, in the chart, for Raymond Garza, bed 4, timestamp 422. Authored by me, my name, my NPI number, my digital signature. I want to be precise about this because precision matters. I am describing a progress note that existed in a patient's electronic medical record, authored under my credentials, time-stamped 1 hour and 49 minutes into the future. The note documented a cardiac arrest. Patient found in ventricular fibrillation on telemetry. 423, code blue called. CPR initiated by RN Martinez. Epinephrine 1 mg IV push times 4 at 425, 429, 433, 437. Defibrillation at 200 joules, 200 joules, 360 joules, 360 joules. Amiodarone 300 mg V push at 431. Sodium bicarbonate 50 milliequivalents at 440. PEA at 448. Asystole at 455. Resident physician Dr. Sarah Chen pronounces death at 5:01. 38-minute resuscitation. Time of death, 5:01. The note was clinically perfect. Drug doses correct per ACLS protocol. Joule settings appropriate for defibrillation sequence. Documentation formatted exactly the way I format my code notes. Attending attestation at the bottom, resident name in the assisted by field, nursing staff listed. 2 problems. Dr. Sarah Chen was not scheduled that night. She was on her surgery rotation. She had no reason to set foot in my ER, and it was 2:33. The events described in the note had not happened yet. I stared at the screen for, I don't know, a minute, maybe 2. I remember the cursor blinking. I remember the overhead fluorescence buzzing, that specific 60 hertz hum that means one of the ballasts is dying. I remember thinking clearly and calmly that there must be a reasonable explanation. There wasn't. The first thing I did was the rational thing. I called IT. Night IT at Cook County in 2018 was one guy named Dennis, working from home in his pajamas, remoted into the system. I'd called him before about epic glitches. We'd upgraded 6 weeks prior and the transition had been rough. Timestamp errors, duplicate orders, notes appearing under wrong dates. It happened. So I called Dennis and told him there was a progress note in a patient chart with a future timestamp, authored under my credentials, and I needed it investigated. Dennis pulled the audit trail. Took him about 4 minutes. The note was created at 02:31, 2 minutes before I'd opened the chart. It was entered from workstation WS-POD DA04, the bedside workstation at Bed 4. Login method, badge tap plus biometric fingerprint confirmation. My badge, my fingerprint. The system showed me physically present at Bed 4's workstation at 02:31. At 02:31, I was at the nurse's station, 30 feet away, pouring powdered creamer into a styrofoam cup. I walked to Bed 4. Garza was asleep. The workstation screen was locked, timed out. Nobody else in the pod. The curtain was pulled halfway. The IV pump was clicking its quiet rhythm. Everything normal. I asked Dennis to check the pod security camera. Cook County had installed cameras in all treatment areas after the federal consent decree. Patient safety, liability, the usual. Dennis pulled the feed from 02 to 2:35. The camera showed the workstation chair at Bed 4, empty. For the entire 35 minutes. No one sat down, no one touched the keyboard. But at 2:31, the keyboard keys began to depress, by themselves, in sequence, for 4 minutes and 12 seconds. Dennis went quiet on the phone. Then he said, "I'm going to escalate this to the vendor." He never called back. I tried to delete the note. Epic does not allow deletion of signed progress notes. The note was signed, my digital signature, my biometric confirmation, my attestation. The system treated it as a finalized legal medical document. I could addend it, I could not remove it. I called the nursing supervisor, Jean Kowalski, been at County longer than me. I showed her the note on the screen. She read it silently. I watched her face. Halfway through, something changed. She looked up at me and said, very carefully, "This reads like a real code note. The documentation is too clean, too specific. Glitches don't write code notes." She was right. I'd written hundreds of code notes in my career. The structure, the pacing, the level of detail, this wasn't corrupted data. This was clinical documentation written by someone who had watched a patient die. At 2:55, I pulled Garza's second troponin myself. Didn't wait for the 3-draw. Sent it stat. Troponin, 0.04 nanograms per milliliter. Normal. His 12 lead was sinus rhythm, rate 72. No ST changes, no reciprocal changes, nothing. By every metric available to modern cardiology, Raymond Garza was not having a myocardial infarction. He was a well-appearing middle-aged man with non-cardiac chest pain who should go home in the morning and follow up with his primary care doctor. I ordered continuous telemetry anyway. Moved him to a monitored bed, told the charge nurse I wanted a nurse within line of sight of Bed 4 at all times. Then I went back to the note, read it again, word by word. That's when I noticed something I'd missed. The note referenced crash cart from Base 6. Base 6's crash cart had been taken out of service at 11 p.m. for expired medications, specifically expired epinephrine. Only the night pharmacist knew this. She'd logged it in the equipment maintenance system at 11:14 p.m. The code note, written at 2:31, said, "Crash cart Base 6, noted expired epinephrine, used backup cart from supply room." That information had existed for 3 hours and 17 minutes. In a pharmacy subsystem that does not interface with Epic, the note referenced data from a system it could not have accessed. At 3:45, I called Dr. Sarah Chen's cell phone. She picked up on the second ring, which was strange for 4 in the morning. I asked her where she was. She said home. I asked if she was planning to come to the hospital. She said no. She was on surgery this month. No ER shifts. Then she paused, and she said, "That's weird. I was actually just putting my shoes on. I had this feeling I needed to come in." I told her to stay home. I told her explicitly, "Do not come to the hospital tonight." As if that would change anything. At 4, I pulled a chair next to Garza's bed and sat down. His monitor showed sinus rhythm, rate 68, blood pressure 128/76, oxygen saturation 98% on room air. He was sleeping comfortably. He was medically fine. I decided I would not leave that bedside until 5:02. 1 minute past the documented time of death. If the note was a glitch, nothing would happen, and I'd have a story for the morbidity conference. If it wasn't a glitch, I didn't finish that thought. Sinus rhythm, rate 70. Garza slept on his left side, one arm tucked under the pillow. The monitor traced steady green peaks. The IV pump clicked. The fluorescent above bed 3 flickered the way it had all shift. I started to relax. 15 minutes to go. Maybe this was a vendor issue. Some corrupted data packet from the Epic upgrade. An elaborate, impossibly detailed glitch. 20. Garza woke up, blinked at me, smiled. "Doc, you look worse than me." I poured him water. He drank it slowly, said his daughter would be up in a few hours starting the tamale dough, and he needed to be home because she always added too much masa. He was a person, talking about tamales. Alive. 21. I watched the monitor. Sinus rhythm, rate 72, NOR 22. Shh. VFib. The monitor screamed. Garza seized once, then went slack. His eyes rolled back and his jaw clenched around the water cup, cracking it. Water ran down his chin. I hit the code button. Code blue, Pod A, bed 4. Flat, automatic, 28 years of muscle memory. Pulled the bed flat, started compressions. Coarse VFib, the exact waveform morphology described in the note. RN Martinez came through the curtain. She'd been walking past. The code card arrived from base 6. The tech popped it open, reached for the epinephrine, stopped. Checked the date. Epi's expired. Backup cart from the supply room. 45 seconds. I ran the code, but I wasn't running it. I was reading from a script I didn't write, executing steps I already knew. Epi 1 milligram at 425 because the note said 425 and I couldn't make my mouth say anything else. 200 joules. Clear. His body arched, still VFib. 200 joules, clear, VFib. Amiodarone 300 at 431. I asked for it before the pharmacist calculated the dose. She looked at me. I said I'd pre-calculated. Nobody questions the attending during a code. 360 joules, nothing. 360 again. The VFib was degrading, finer. Bicarb 50 at 0440. Exactly. 448, PEA. A rhythm on the monitor, but no pulse underneath. The heart's electrical system firing into a muscle that won't respond, like a phone ringing in an empty house. 455, asystole. Not the dramatic movie kind. The kind where the monitor just stops drawing peaks. The double doors opened. Dr. Sarah Chen walked in wearing street clothes. She'd driven from Wicker Park because she couldn't stop herself. Told me later she got in her car at 0410 on autopilot, parked in the attending lot she'd never used, walked straight to Pod A without asking anyone where the code was. She looked at the monitor, looked at me. Time of death, 0501. 38 minutes. Every drug, every dose, every joule, every timestamp. Exact. I filed the incident report the next morning. IT investigated for 3 weeks. No breach, no malware, no unauthorized access. The biometric data matched my right index fingerprint, 99.97% confidence. I requested the security camera footage one more time. Legal made me sign a HIPAA acknowledgement. I sat in a windowless room in risk management and watched a 60-second clip. The workstation at bed 4, empty chair. At 2:31, the keyboard keys begin to depress and release in sequence. Normal typing speed, 4 minutes and 12 seconds. No hands. Raymond Garza's autopsy. Massive acute MI, 99% occlusion of the left anterior descending artery. The Widowmaker. That same artery, 0% stenosis on the cardiac cath done at 11 a.m. that day, 14 hours earlier. A coronary artery does not go from patent to 99% occluded in 14 hours. It is not physiologically possible. The note is still in the chart. My name is on it. Epic retains for 25 years. It will be there until 2043. The last thing, the thing I left out of the incident report. When I reviewed my audit trail that morning, there was one more entry, a discharge summary, authored under my NPI, timed at 07:15. At 07:15, bed 4 was empty. Garza was in the morgue. The discharge summary was for a patient named Margaret Hollis. 63, hypertensive emergency, disposition, home with follow-up. Margaret Hollis was admitted to bed 4 at 18:20 that evening, discharged at 22:45, hypertensive emergency, home with follow-up, every detail matched. I resigned 6 weeks later. I teach documentation courses now, proper progress notes, correct timestamps, how to sign your charts. I don't log into Epic anymore, but sometimes, around 2 a.m., I think about checking, just to see if there's another note with my name on it.